This is a CT scan of a patient with Wegner's granulomatosis or granulomatous polyangitis, which is a systemic autoimmune disease, who has been on treatment with immunosuppression for the past 3 years. Now she presents to the rheumatology clinic with persistent pain and discomfort on the left side of face and headaches and profuse discharge. The CT here shows selective opacification of the left-sided sinuses, including maxillary, ethmoid, sphenoid, and frontal, as well as the right-sided sphenoid and posterior ethmoidal complex. What you also see is a large septal perforation, which is again very common with the vaginal granulomatosis, which affects the nose, the sinuses, the ears, the respiratory, and the renal system. Now, with this large perforation and this tissue that you see, though the scan looks pretty normal in like a routine sinusitis case would be, one must alter the expectations going forward in such cases because one can have a very poor surgical field. The patients being already on plenty of immunosuppression, you could have unknown infections here, and you can see that how there's a large septal perforation, and there's always this the entire sinus cavity seems to be full of very friable tissue, uh, uh, which is very unpredictable, and one mustn't expect any landmarks in this kind of surgery. So one has to go slow, go from anatomic landmarks, whatever you find. We do not see any middle turbinate here. We just see a lot of slough, etc. And one must go from sinus to sinus and from known landmarks such as the choana to always well preserved, the tail of middle turbinate that you see here, the maxillary antrum, which is open by itself. But as you see, even the slightest contact of the mucosa with the suction or any blunt instrument leads to bleeding. So these patients will always trouble you. Will always be a potential of ingress into the lamina papyraceae, orbital trauma, or anything else. And one must be cautious here. The goals of surgery must be well defined, which here are obtaining of generous amounts of tissue for bacterial cultures, histopathology to prove any, find any atypical infections, presence of fungal infections because the patient is immune suppressed. But as we see here, it is a remarkably oozy field, a very suboptimal field, so to say. And one must take your time here in such patients and proceed from anterior to posterior and medial to lateral in a very structured way, and from dissecting cell by cell so that one does not have any unfortunate complications. Navigation 2 here is a good tool to use, though it was not used in this patient, but otherwise it can be used in such patients. What you see here is the tail of middle turbinate almost instantly, whereas the rest of the middle turbinate is barely recognizable scarred. We have the maxillary antrum, which can help us as being a landmark. The posterior vertical ridge of the maxillary antrum and the horizontal ridge of the maxillary antrum are guiding points towards entry into posterior ethmoids and the sphenoid. As we are using the shaver, we see bone chips, bone fragments, hair. This could be the portion of the middle turbinate or the superior turbinate, tail. And as you see here, any amount of surgical work here or use of shaver creates bleeding and trauma. We start clearing the maxillary antrum first because the maxillary antrum is a very important landmark. The roof of antrum, the roof of maxillary sinus, or the floor of the orbit is a very important guiding point towards entry into the sphenoid sinus, whereas the transitional ridge, where the roof of the maxillary sinus transits into the posterior vertical ridge of the maxillary sinus, is a very important guiding point towards the entry into the posterior ethmoids to avoid the skull base. Now we keep on going posteriorly, and initially we take notice or take or make a point to stay medial and inferior along the lines of the maxillary sinus to avoid any skull base trauma, to basically locate the sphenoid. In the presence of a large septal perforation, it's also very common to reach the opposite sphenoid sometimes because the angulation of instruments that must be borne in mind. That in this case is fine because we want to do an extended sphenoidotomy, where we convert the entire sphenoid of both sides into one, because the posterior septectomy is already done. Once we have opened the sphenoid, we resort to enlarging it using bone punches and shavers to be able to again reorient ourselves into the three-dimensional anatomy of the sinuses in this precarious situation. So we enlarge this sphenoid opening laterally and superolaterally and inferolaterally. And once again, the choana is an important guiding point. Now, if you notice, the choana is much more medial than the sphenoid we have opened. So this has to be the opposite side sphenoid, which is basically the right side sphenoid and the posterior ethmoid, as you see. And that has been opened and sort of cleared. What is left now is the ipsilateral sphenoid that ought to be above the choana in this bleedy and suboptimal field. We also have to open the ethmoids completely, and in the end, the frontal sinus as well, to be able to give this patient not only a good tissue diagnosis, but also a good clean cavity for the patient to irrigate steroid infused washes. We are removing the ethmoid septations one by one with a mix of use of the microdebrider and cold instruments. Sometimes a Blacksley is helpful. Otherwise, one can use a, a true cut. Here we are using a little bit of debridement inside the frontal recess area to be able to navigate our way superiorly. Having orientation of the orbit, the skull base is very, very important in this situation. Frequent irrigation definitely helps. As you see there, now we are finding our way inside the frontal sinus. The frontal sinus is now open. One can nicely visualize the frontal beak. We are still clearing some amount of loose bone or unhealthy mucosa from this area. Again, the point being you being able to irrigate in the post-operative period for a long, long time to reduce dependence on the systemic steroids. Now we are using a 70-degree angled endoscope and an angle microdebrider to basically work in the frontal sinus area. One must also be cautious of the anterior ethmoidal artery, which is just here at the same location, and not to traumatize that using a microdebrider blade. So once we have opened the frontal sinus, the anterior, the ethmoidal skull base is in front of us with some excess mucosa. We are now seeing if there's anything else that we need to clear from the frontal sinus, any necrotic bone fragments or any diseased mucosa from this area, so that we are able to get off all dead tissue from this area. So again, we are cautious. We do not want to expose a lot of bone here to avoid any poor healing, which is a hallmark of this disease. We have not encountered any fungus here, and our angled view inside the maxillary sinus shows that we are more or less good, and most of the diseased mucosa has been removed and sent for appropriate examination for bacterial and fungal cultures separately, as well as for histopathology. Now, tissue cultures are very important because they reveal much more than any pus culture, and that's much more important in these kind of patients where the propensity for atypical infections is much higher as compared to routine patients who are not on immunosuppression. Now that we have cleared almost all, the ipsilateral sphenoid is yet to be opened. Now we can use the superior maxillary roof or the medial orbital floor to guide us inside the ipsilateral sphenoid. As we see here, our suction is going inside the sphenoid on the other side, and we can see how the sphenoid on this side is completely still not open, and we will open it now and sort of remove the intersphenoid septum partly to be able to convert this into a single sphenoid cavity, which is highly amenable to nasal douching and irrigation using steroid infused saline. Once you have seen what our level is, as you can see here, We are just following the maxillary sinus roof or the orbital floor for an approximate entry into the sphenoid sinus, and there we are. The sphenoid on the ipsilateral side also has been opened. And apart from general opening, we can just use a little bit of soft tissue to be cleared using the microdebrider blade, and rest of it, if needed, can be cleared using a bone punch. A Kerrison bone punch is a wonderful tool, and almost everything can be accomplished in a sinus surgery with this single instrument in the absence of a microdebrider blade. Now again, one must be cautious not to transect the septal branch of the phenopharynggeal artery in these patients to avoid any bleeding. Though already there is a septal perforation in place, but still it is a sort of a small complication that is best avoided. Now one can see how the sphenoid of both sides is now open, and we can see it through the perforated septum that is, transrostrally, and how the level of sphenoid is so well understood with regard to the level of the maxillary sinus. Now orientation is better. One can see both sphenoids. The rostrum is clearly visible. The maxillary sinus, which is clear. The sphenoid 2 appears okay with just some diseased mucosa which has been taken for appropriate samples. And this is an angled 7-degree view of the ethmoidal roof, the fovea, and the frontal sinus, which appears to be also clear of any gross disease, at least. The posterior tubular and the anterior wall of the frontal sinus are very clearly seen, with very little, if at all, any bone exposure in this patient. Now, when the landmarks are distorted in scarring, one has to rely on nearly always available landmarks. Most important of which is the maxillary sinus, which needs to be widely open, the choana, and once you start identifying the skull base posteriorly, one can follow it superiorly towards the frontal sinus. Ample amount of irrigation is very important before we close this case.